Thoracic trauma, on these things, we'll be discussing the introduction, the incidence of thoracic trauma, the concept of golden hour, pathophysiology, approach to trauma, investigations, deadly dozen, tube thoracostomy, and thoracotomy. If you have time, we'll do this thoracotomy, but depending on the time, we'll decide. Yeah. Thoracic injury occurs in 20 to 25% of the trauma patients. 20 to 25% of trauma patients. 25% can be fatal and 80% can be managed conservatively. Mortality rates from military thoracic trauma have steadily declined from 63% in American Civil War. So this American Civil War was between 1861 to 1865. It was between the northern states of US and the southern states of US. It was one of the war which was maximum studied actually. There, the mortality was severe, like 63% because of thoracic trauma. And later in the later half of this 20th century, that is in the 1950, there was a Korean War between the Northern Korea and the South Korea. And even in the Vietnam War, between the North Vietnam and the South Vietnam, if the thoracic trauma, the mortality rate had significantly decreased to 2 to 4%. And one of the main reason for is the ICD insertion, that is the tube thoracostomy, which I'll be explaining in detail. Coming to the golden hour concept. What is this golden hour? Golden hour is the first 1 hour after the surgery. Immediately after the, just 1 hour after the trauma. This 1 hour after the trauma is a very, a golden period, because in intervention in this golden hour can save lives, especially in thoracic trauma. So after trauma, the deaths occur usually in the 3 periods. One is immediate death. Just after the trauma, a patient may have sudden aortic injury. So a patient will have severe high spinal cord injury, severe brain injury. So all these causes is not at all salvageable. And only prevention can prevent this immediate deaths. This is the immediate death. Coming to the next group of patients, that is the second group of patients, where the patient usually die in the initial 24 hours after injury. And for thoracic trauma, the first 1 hour is considered as the golden hour. And any intervention at this period can save a lot of lives. The brain and abdominal injury, the deaths usually occurs between the 6 to 24 hours period. Last, the late deaths occur days to weeks. And the major cause is due to sepsis and multiple organ failure, which happens. So the deaths usually is divided into immediate death, then initial 24 hours, and the late deaths, which occurs days to weeks. Now, the most common, in thoracic trauma, you have either pneumothorax or hemothorax. Any one of the residents want to try, pleura can accommodate how much liter of fluid or blood? Anyone wants to try? It's an interactive session, so please do participate. Okay. Anyone
10 to 15, yeah. 10 to 15 ml, boss.
So, no, pleura can accommodate much more actually. Pleura can accommodate 3 liters. 3 liters it can accommodate. Pericardium, maximum it can accommodate 100 to 200 ml. Some books even have mentioned just 50 ml. So you get a severe tamponade effect in pericardium if you have a blood of 100 to 200 ml. So there is a famous saying that bleeding occurs in 5 major sites. 1 on the floor and 4 more. 1 on the floor, that is external, which is obvious. Then the others can be chest, abdomen, pelvis, and extremities. Coming to the pathophysiology of trauma. The pathophysiology, it can be either blunt or it can be penetrating injury. The blunt injury, the major thing it causes is the pulmonary contusion, which can lead to acute lung injury, or the adult respiratory distress syndrome, that is accumulation of fluid inside the lungs, inside the alveoli, or even later stages, it can cause ventilator-associated pneumonia. And next, coming to the penetrating injury. Penetrating injury usually is caused by a knife or the bullets or the projectiles. So projectiles have been divided into low velocity projectile and high velocity projectile. Low velocity projectile is if the velocity is less than 500 feet per second. If it is less than 500 feet per second, it is called a low velocity projectile. And high velocity projectile is if it is more than 3,000 feet per second. If the speed is that much, then it is called as a high velocity projectile. Lung is especially susceptible to barotrauma. So, for example, any blast injury, they are very susceptible to barotrauma. The other organs which are susceptible to barotrauma is eardrum, then the intestines. Any hollow viscous injury, any hollow viscous organ is susceptible to barotrauma. Coming to the next, the abbreviated injury scale. So in abbreviated injury scale, there is another description of head, neck, face. I mean, the various parts of the body, there have been specific numbering has been given. Anyone knows the numbering? Anyone wants to try the numbering of each of the organ? Any residents who know can attempt trying it. Okay, I'll just tell you. First is the head. Head is given as 1. The numbering is head is given as 1. I'll just draw a body. Yeah. So head is 1, 2 is face, 3 is neck, 4 is thorax, 5 is abdomen, 6 is at the back, 7 is the upper extremity, 8 is the lower extremity, and 9 is any external part. So numbering of each and every organ is given a numbering like this: 1, 2, 3, 4, 5, 6, 7, 8, and 9. 4 is for thorax. And for thorax, then the severity of the scoring is also given, whether it is minor, moderate, severe, critical, and maximum injury, which is unsurvivable. So if a patient has a score of 6, I mean, that is patient is not at all survivable. There is another common scoring, anatomical scoring given in trauma, which is known as ISS, Injury Severity Score. Anyone knows what is ISS in this? Any residents who want to try what is ISS?
Yes, it is like A square plus B square plus C square, in which A, B, C are respectively the maximum injured region, then followed by the second maximum and the third maximum injured region, and overall it is given as a code to 1 to 5. I guess.
No, what is the maximum score then in ISS?
In maximum would be like 5 square would be 25, then it would be 75.
Yeah, you're perfectly right. So this is ISS scoring. The maximum score is 75. So what happens is, what you told is absolutely right. So the maximum scoring, that is, for example, if a patient has a scoring of 5, a patient is having a 4, and a patient is having 3, it is 5 square plus 4 square plus 3 square. So the maximum score can be 5 square plus 5 square plus 5 square, that is 75. If any patient has 6, that means death, which is not included in the scoring, ISS scoring. Perfect. And for thoracic trauma, minor is considered as 1 rib fracture. 1 rib fracture is considered as minor injury. 2 to 3 rib fractures or sternum fracture is considered as moderate. 4 or more rib fractures or lesser fractures like 2 to 3 rib fractures with hemo or pneumothorax is considered as serious one. Severe fracture is flail chest. And 4 or more rib fractures on each of 2 sides, or 4 or more rib fractures with hemo or pneumothorax is severe, and bilateral flail chest is considered as critical. So like this, you do the scoring for thoracic trauma. Now, next, a patient comes with trauma. How do you approach the patient? First, the basic norm is always the primary survey. That is CABC. It includes catastrophic hemorrhage, the control of hemorrhage. Also includes C-spine clearance in trauma, C-spine clearance, airway, breathing, and circulation. So all the CABC comes under primary survey, which has to be done immediately when the patient comes. Primary survey. After you finish, and then what are the clinical indicators of ongoing bleeding dorsal trauma? That is the thorax trauma. It can be either anatomical or physiological. Anatomical is visible bleeding. So in a thorax, there is a visible bleeding is present. That is a anatomical thing. Injury in close proximity to major vessels. The most common injured vessel in thorax is the intercostal vessels, followed by the internal mammary vessels. Penetrating injury with a retained missile in the thorax. Then increased respiratory rate, increased pulse rate, and falling blood pressure, and raised serum lactate. So a person who has a pericardial tamponade, then what are the clinical signs? Anyone wants to, who knows the triad of pericardial tamponade? Any resident?
Sir, elevated JVP, muffled heart sounds.
And
Hypotension.
Hypotension.
yeah, hypotension. So what is a triad known as?
Beck's triad.
Beck's triad. Perfect. Today we have a lot of brilliant residents here. Beck's triad. Very good. So that is decreased BP. It is all usually associated with increased pulse rate, increased JVP, and muffled heart sound. Perfect. So this is pericardial tamponade, and we need to suspect a pericardial tamponade during our primary survey itself. And it is also very essential to know the upper and the lower extremity pulse. We need to see the pulse in all the limbs, the right side, left side, upper limb and lower limb. All the 4 parts you have to see the pulse. That can be a sign of thoracic aorta injury or subclavian artery injury. Next is secondary survey. Secondary survey, the very common mnemonic is the sample SAM PLE. Who wants to attempt? What is the sample? Any resident who's interested in telling the full form of sample in secondary survey?
May I?
Yeah, sure.
A for allergy, and then
A for allergy.
ongoing medications, then past medical history, and the pregnancy history, whether if it is a female, then she's pregnant or not, and then L is the last meal time, and I forgot about it. Sorry.
Any other resident?
This has been taught for years, every 6 months, for years.
Events in trauma.
Events leading to trauma and environment. Environment and events leading to.
And
anyone
P doesn't stand for pregnancy.
Sir, actually, some even I saw some text actually mentions pregnancy, sir. I mean, that was through net. I saw past history was also included and pregnancy was included. I don't know, sir.
Anyway, then S is not covered. The S part was not covered in sample.
S is secondary survey. S is for secondary agreement, sir. Yes, sir.
Okay.
Yes, sir. Secondary survey. This is the mnemonic. Yeah. Anyone wants to attend? What is it? Tertiary survey?
Yeah, I can answer. Tertiary survey is done after 24 hours so that we cannot miss any injuries. So you start from the head and neck and go up to the toes. Head and neck, you will have to see what are the injuries and then chest. You go for inspection, tenderness, all this air entry, abdomen, bilateral upper limbs, including the pulses, full range of movements, and bilateral lower limbs, and the back and the spine.
Yeah, you're absolutely right. Only one thing, head-to-toe examination comes under secondary survey, but tertiary survey is just that you revisit all the things in secondary survey, and it's a complete examination so that you make sure that nothing is missed. So that is tertiary survey, and as you told exactly, it is after 24 hours, and which is ideally to be done before 48 hours. So after 24 hours and before 48 hours, ideally it has to be done the tertiary survey, so that nothing is missed. Then they
I would like. Hello.
Yes, sir.
Can I?
Yes, sir. Yes, sir.
I want somebody to tell how to clear the cervical spine clinically. To some volunteer. Hello. Anybody to answer how you can clinically say cervical spine is clear?
Sir, we assume the cervical spine is injured and we put a hard cervical collar around it, sir.
No, not in everybody. Okay, I will finish it. in an alert, non-intoxicated person. First thing is alert, no intoxication, no analgesic. When the cervical spine has full range of pain-free, active and passive movements and no tenderness on the spinous process, then you can say cervical spine is not injured.
Yes, sir.
I'm repeating, full range, active and passive movement, no tenderness in an alert, non-intoxicated, without analgesics. Right? Here also, I would like to raise one more point before we proceed. There are two common injuries missed in tertiary survey and all over. What are those two common injuries which are missed in thoracic trauma? One is fracture clavicle, the lateral end. Second, impacted fracture of humeral head. If you really don't look for it, most patients are on ventilator where these things are missed. And the portable chest x-rays do not show the lateral end of the clavicle. And even if the humerus is done, until you really look for an impacted fracture, you are likely to miss one. So these are two important things. Third thing is, if on plain x-ray, chest, AP view, if you see 4 rib fractures, there are always 3 more, which you can see on CT, but not on plain X-ray, right?
Yes, sir.
So with this background, you proceed. Very
Yes,
nice.
So they have found that there are 3 significant factors in determining the early deaths in thoracic trauma. This is a thoracic injury with chest abbreviated injury score greater than 4. Greater than 4 is critical. 4 is critical. So mild, moderate, severe, and 4 is critical. So if it is more than critical or 5, then there is an increased chance of mortality. Then a GCS score less than 8 and a systolic blood pressure less than 90 millimeter mercury. So these are one of the 3 significant factors in thoracic trauma. So after the thoracic trauma, initially you do the investigation. The first investigation is EFAST. So I've just given an option. I mean, MCQs, I think everyone will be solving. So what is the full form of EFAST? We have 4 options here. You can all see it.
Extended focused on assessment with sonography for trauma.
Exactly. Extended focus assessment with sonography for trauma. I mean, these are the common questions, especially when you're attending NEET SS questions and NEET PG questions. So don't get confused. It is extended focus assessment with sonography for trauma. So what is this extended? So first I'll talk about the FAST. In FAST, initially, first we see the pericardium, that is 1. We look for pericardial effusion or any hemorrhage there. Then comes 2. You can see my highlighter 2. In 2, you see the near the liver. You see in the 3, you see the perisphenic space. When you see the pelvis, you see in the pouch of Douglas, or that is the rectouterine pouch, or the colovesical pouch. You see any bleeding is present in males. Then this is the FAST. So 1, 2, 3, 4 covers the FAST. So here we have an extended FAST. So extended FAST, they added these 3 things: 1, 2, and 3. So what happened is, after the pericardial window, you see this is the USG probe. Once you see the pericardial window, you also rotate the ultrasound probe like this vertically, and you see the IVC. You see the IVC whether it is distended or not. You see the IVC whether it is distended or not. See the width of the IVC. That is part of extended EFAST. Then after you do 1, 2, 3, 4, you also do 5 and 6. That is at the second intercostal space at the midclavicular line. You see for any pneumothorax, that is 5 and 6. any hemothorax can also be appreciated in 2 and 3. That is 2 and 3 also we can appreciate any hemothorax. I'll show you the various EFAST pictures here. So when you start with the pericardium window, this is how you see the heart. This is the left atrium, left ventricle, right atrium, and right ventricle. So how does a pericardial effusion or pericardial tamponade look in EFAST? Here you can appreciate the hypoechoic area, that is the fluid collection. And what happens is, once there is a pericardial tamponade, you can see the RV in this picture. In this picture, you can see the RV. RV is completely collapsed. So can you appreciate the RV is completely collapsed? That is due to the pericardial tamponade effect. Here you can see the appreciation in the first picture. In this picture, you can appreciate that there is a free fluid around the heart, but there is no compression of the RV. Here you can appreciate the compression of the RV. Then when you see the right side, the perihepatic space. So what happens is, this is a normal, here you can see that there is in EFAST, there is a normal and you can see a pneumothorax. In normal thing, anyone wants to, here I've written already the signs. So the seashore sign is seen in normal lungs. So here you can appreciate, this is the lung and this is the pleura. You can see the lung sliding over the pleura. It is like the waves. In seashore, you can see the waves going on the beaches. So similarly, the lung slides on the pleura to be seen as a seashore sign. So this is a normal EFAST picture, and you can also see. I'll just rub it here. You can just appreciate the comet tail artifact here. So here, this is a comet tail artifact which is seen in a normal ultrasound. This artifact, this comet tail artifact is absent in pneumothorax. There is no lung sliding. And there is some new sign called barcode sign or stethoscope sign. Here you can see in M mode, there is just waves, continuous waves like this. This is a barcode or the stethoscope sign. And here you can see the, you can see the lung sliding over the pleural line, which is known as seashore sign. Only thing about EFAST is the learning curve and operator expertise varies from person to person, so it can be variable. So that is one major disadvantage of ultrasound. But otherwise, it's one of the very important tool, and it is also considered as a part of clinical examination. Next is X-ray. X-ray is one of the most important tests in thoracic trauma. Am I connected?
Boss,
Yes,
I would
boss.
request just to repeat the image in the left also. We missed that image also.
Yeah.
Yes, this one,
Am I
the lung
audible?
and the liver one.
Yeah. Oh, this one I didn't explain. Okay, sorry. So this is the right side. So lung and the liver. What happens is when you see at the two is actually when you're seeing here, that is the right upper quadrant. What you see is this picture. Anyone wants to know that? Can anyone give the diagnosis of this spot diagnosis of this one?
It's a right side hemothorax.
Yeah. So why do you say it's a right side pneumothorax?
See, there is a window between the liver and the lung. And when you take the probe exactly and touch laterally and touch the bed of the or trolley of the patient, usually you don't see any gap between the lung and the liver. If there is a gap, and it means that there is a hemothorax.
Exactly.
So
this is
basically you try to see in EFAST, you try to see either the pneumothorax by putting your probe on the anterior side 5 and 6, or the hemothorax when you do it on the lateral side.
Exactly. Very true. And if you have here, if it is black in color, if it is hypoechoic here, what is this? What is this structure? I'm keeping my highlighter. So what is this structure which I'm highlighting here? Anyone?
This is a hemothorax.
Right kidney.
Fluid.
No, I'm telling, I'm keeping a highlighter here. What is this structure? Just rub it here with, or this line I'm drawing. What is this structure?
See, below the liver, the kidney comes, no?
Exactly. So what is this space between the liver and the kidney?
Morrison's pouch.
Exactly. So if you see a, hypoechoic region here, then it is a, then there is a hemorrhage here also. That is in the
Free
Morrison's
fluid, yeah. There is a free fluid there. Need not be hemorrhage.
That is fluid. Hemorrhage or fluid, any fluid present. Very true. I mean, the subhepatic space, if there's fluid here, you get in the Morrison's pouch. So this is one thing which is very important too. So next, coming to X-rays. X-rays is the most, one of the most important tests in thoracic trauma. So coming to the basics of chest X-ray. First we are starting with normal. What is normal chest X-ray? This is the anatomy. So here you can appreciate the trachea. This is the aortic arch. This you can appreciate. This is the pulmonary artery. This is the left pulmonary artery, and this is the right pulmonary artery. Okay, this is the right atrium, and this is the left ventricle. And here you have the diaphragm. Diaphragm here. Yeah, and this is the stomach. Okay. Okay. So what are the this X-rays mainly first used to find fractures, pneumothorax, pneumomediastinum, aortic rupture, tracheobronchial injury, lung contusion, cardiac trauma, and ruptured diaphragm. All these things, you can have a brief idea with the X-ray. So what is this first X-ray which I'm showing it to you? Any findings? Something which is obvious?
I'm not very sure, Dr. Shyam. Most probably it's a pneumothorax. Because I'm not, usually we see it on the console and we enlarge it and, try to see it.
I think maybe the quality is a little bit disturbed during projection. So this actually here, you can appreciate there's a fracture here. Once again, I'll just draw a line here. Here you can appreciate here a fracture. There's no pneumothorax in this. You can see all the lung markings. You can appreciate the lung markings here. It is completely full. So, there's no pneumothorax here. You just have a fracture. Okay. So fractures, you need to know what is a flail chest. Anyone, any definition of flail chest? It's a very flail chest. Most of the textbooks have given different definitions. Anyone wants to try what is flail chest?
Yeah, fracture of two or more ribs, two or more places.
Yeah, I will accept with this definition. Sir, your point, sir?
There is one point missing.
Consecutive or continuous?
Yes.
Yes.
Yeah,
that point was missing. Okay, good.
Yeah, very good. Next, coming to X-ray in a pneumothorax. So in pneumothorax, we need to appreciate the visceral pleura. The visceral pleura, there is a distance between the visceral pleura and the parietal pleura. The visceral peel. The visceral pleura, you can see the distance between the visceral pleura and the parietal pleura. If it is less than 2 centimeters, we call it as a small pneumothorax. And if the distance is more than 2 centimeters between the visceral pleura and the parietal pleura, then we call it as a large pneumothorax. So what is the ideal way you need to take an X-ray so that you can very well appreciate a pneumothorax? Any volunteers here?
Very well appreciate the minimal pneumothorax.
Yeah. For minimal pneumothorax, what maneuver can you do so that a pneumothorax can be appreciated well? Any volunteers? Okay, so I will tell it. So you take the X-ray first in erect position, then at expiration. So at these two manuals, most of the pneumothorax can be identified. So here, this is a picture in the right side. There's a clear pneumothorax. I'm sure you can all appreciate this is the lung. This is the lung here. There is no lung vascular markings here. So this is a clear diagnosis of left pneumothorax. This is a massive pneumothorax. Sorry, a massive pneumothorax. Massive pneumothorax. This is the visceral. Here you can appreciate the lung border, and this is the air in it. Now, usually a trauma patient, sometimes he cannot be erect. Sometimes he's just in supine position. So during supine position, how do you identify a pneumothorax. It's a little difficult. So at this juncture, what you can do, what happens is the air is displaced anteriorly and at the base. So here you can see just at the diaphragm, you can appreciate the small air. So during supine position, you just have to look near the diaphragm, and if there is an air here, then it is a pneumothorax. I just erase it so that you can appreciate the air thing, so that the diaphragm is clearly visible here in the right side. Okay, and the left, and again, and the other picture in this one, you can appreciate the pneumothorax. This is called the deep sulcus sign. Deep sulcus sign. Here you can appreciate the pneumothorax here. It is deep here like this. So this is also in supine position. When you take an X-ray, you have to look near the diaphragm. You also have to look at the sulcus. So this also in supine position. This is actually a case of right side pneumothorax. Next, coming to the another important diagnosis is pneumomediastinum. So if air accumulates in the mediastinum, it's called pneumomediastinum. The most common cause can be alveolar rupture due to various causes: mechanical ventilation, underwater driving, marijuana smoking, cocaine, spontaneous, and thoracic trauma can definitely close and penetrating injury and other causes. So here you can in this right, left side, you can appreciate this sign. And this is a typical case of pneumomediastinum. Anyone wants to attend the sign of this? There's a actually named sign for this. Anyone? What is this sign? Can you appreciate here? This is an angel wing. This is called angel wing sign. Angel wing sign. Here, this is actually the wings of the angel. So here is the wings of the angel. This is common only, especially in a neonate. In neonate or small children, you can appreciate this angel wing sign. In adults, there's another sign for pneumomediastinum called as, any diagnosis for this sign? Anyone knows the sign of this? It is called continuous diaphragm sign. Continuous diaphragm sign. Here you can appreciate the diaphragm is continuous and there is air just above the diaphragm. So this is known as continuous diaphragm sign. So what happens is, if there is any alveolar injury or any esophageal or even tracheal injury, so what happens is, if there's an alveolar injury, the air goes near the hilum and then it goes to the mediastinum. So in the mediastinum soft tissue, it gets accumulated. So we need to know a difference between what is a pneumothorax, pneumomediastinum, and pneumopericardium. So this is actually just beside the heart. If you have, along the lungs, if you have this kind of air, it is called pneumothorax. Pneumothorax. This is pneumomediastinum. And pneumopericardium. So what other X-ray can you do to differentiate between a pneumothorax, pneumomediastinum, and pneumopericardium? Anyone? A little difficult question. In X-ray itself, I know definitely a CT will do the diagnosis, but in X-ray itself, what other can you do if you don't have a CT scan? What can you do to differentiate between pneumothorax, pneumomediastinum, and pneumopericardium? You can do the X-ray in lateral decubitus position. Lateral decubitus position. So if you do an X-ray in lateral decubitus position, in a dependent field, the pneumothorax is obvious near the, the visual pleural peel can be, a visual line can be seen. That is a pneumothorax. In pneumomediastinum, there is no change in lateral decubitus position. There is no change. And in pneumopericardium, that is the non-dependent part, there is more air accumulated in pneumopericardium. So this is how you differentiate between the pneumopericardium and pneumomediastinum in lateral decubitus position. Okay, they're coming to the next X-ray, widening of the mediastinum. Here you can see there's a definition for widening of the mediastinum. Widening of mediastinum, I'll just write it down. Widening of mediastinum. So it is defined as if, one second. Sorry. At the level of the aortic knuckle, greater than 8 centimeters, or if it is more than 1/3 of this interthoracic line, if it is more than 1/3, then it is known as widening of the mediastinum. I mean, transthoracic line, if it is more than 1/3, or if it is more than 8 centimeters, it is known as widening of the mediastinum. The most common cause is the injury of the aorta at the level of isthmus, and also small vessel injury can also cause widening of mediastinum. Okay. What is this next diagnosis? This X-ray. What is this X-ray? And what am I trying to show here? Any residents? What is this X-ray and what am I trying to show here? Okay, this is nothing but a tracheobronchial injury. Okay, a tracheobronchial injury. So what happens is after tracheobronchial injury, there is a massive pneumothorax. You can appreciate the pneumothorax. There is it's definitely more than 2 centimeters. There's a large pneumothorax here. And you insert an ICD. And after insertion of ICD also, there is still pneumothorax. There's persistence of pneumothorax even after ICD insertion. That is lung fall even after ICD insertion. Then you need to suspect a tracheobronchial injury. Okay. Next, in X-ray, another very important is lung contusion. Lung contusion, it can look like a cavitation. It can look like a consolidation. So what are the findings you can appreciate here in this X-ray? In this X-ray, once again, I'm slightly enlarging it. Any residents? What are the findings you can see in this X-ray? Any residents?
Was continuous 3 ribs. It is showing fracture and most likely flail chest.
Huh? Yeah, that is rib fracture. You're right. Next, second, any other thing? I'll just draw and give you a clue. What is here? I'm drawing and showing you. So any diagnosis?
There's an opaque shadow behind it.
No, what is this border? What is this border? What is this border?
Collapse lung margin.
Lung margin. So what is this?
Multiple rib fractures with pneumothorax.
Pneumothorax. Exactly, pneumothorax. So you can see the lung border, right? You can see the visual lung border. Then definitely there's a pneumothorax. Third, what is the other third finding here? Can you appreciate a consolidation here?
Pulmonary contusion is there.
Yeah, pulmonary contusion. So there are 3 findings here. Here you can appreciate the rib fracture, you can appreciate the pneumothorax, also a lung contusion. Very good.
I would like everybody to know what is a contusion. We talk it often, but we should be all clear how do you define contusion on an X-ray. The exact definition is non-anatomic radio-opaque patch in a trauma patient is considered a contusion. It does not follow an anatomical pattern. Mostly the boys miss non-anatomic part. Okay.
Yes, sir.
Sir,
Okay, next quarter.
Sorry, sir. How you can differentiate in X-ray chest the pulmonary contusion and pulmonary laceration?
Pardon?
And
pulmonary?
Contusion and pulmonary laceration. On
You
the basis
cannot.
of X-ray test.
You cannot. You will find the chest X-ray, you cannot. On CT, you can find it.
Yes, sir. Thank you, sir.
You're suspecting bleeding, you do a CT angiography.
Then there is another term. What is an occult contusion? A contusion not seen on chest X-ray and picked up on CT scan is called occult contusion.
Yes, sir.
And it does happen because in major high velocity trauma, when you do an immediate chest X-ray, it will be normal. But when the patient is tachypnic and there are signs of respiratory failure, then currently we do CT nearly on every major chest trauma. So it is picked up early.
Yes, sir. Okay. Moving on to the next spotter. What is this chest X-ray? Spotter diagnosis. Patient has had a blunt trauma. So what is this diagnosis?
Left-sided diaphragmatic elevation. Left-sided diaphragmatic elevation.
So what is this?
Hiatus.
Hiatus. Can you appreciate the fundal shadow also? Small fundal shadow. So this is definitely a diaphragmatic hernia with the herniation of the stomach. Okay. So the diaphragmatic rupture can either occur through from right side or left side. Which side is very common?
Left side.
Yeah, left side. Almost the ratio of 1:4. I mean, that 75% is usually due to left-sided trauma. And usually it occurs at the level of central tendon. So in diaphragm, we have something called central tendon here and the muscular part. This is the muscular part. And this is the central tendon. So at this level of central tendon, usually the vascularity is little less compared to the muscular part. And there, the rupture is more common. Okay. So rupture of both right and left domes of diaphragm. Diaphragm is injured in approximately in 5% of severe thoracic injuries and 22% of thoracoabdominal injury. Definitely, there is a high positive pressure in abdomen and negative pressure in thorax. So that's why in abdominal trauma, the diaphragm rupture is more common. And 33% of these injuries are diagnosed very later after the trauma. You can see a diaphragmatic elevation, very later stage, and then you diagnose a diaphragmatic injury. Next part of
here I would like everybody to know what is the most sensitive test to diagnose diaphragmatic injury.
Ultrasonogram.
Most sensitive test.
Endoscopy.
Which? Upper GI, lower GI?
Upper GI.
Very good. Anybody else?
Sir, laparoscopic surgery, sir.
Diagnostic laparoscopy. My question, try to appreciate the question. Your answer is right, but your modality of words are not right. When I asked which is the most sensitive test, the answer is diagnostic laparoscopy. Okay. That is only 100%. All other things are less than 100%. All right.
Yes.
So,
now actually,
Shyam, what?
Yes, sir.
You know, my current feedback is that the attention span of current population is 45 minutes.
Yes, I'm just finishing it, sir. With the investigations, I'm finishing it.
And then we'll
finish. Wrap up, sir. Yes, sir. I'm just finishing with the investigation.
Yes.
So the next important part of investigation is ECG. ECG, we need to look for any arrhythmias, any ventricular, premature ventricular contraction, any bundle branch block. So this is indicative of blunt cardiac injury. And the other important investigation is definitely CT. And if there is hemorrhage or bleeding suspected, you do a CT angiography. And when there's no time for radiological investigation, when you don't have, the patient is in shock, the patient BP is decreasing, the pulse is increasing, then you do something called, it's a diagnostic and a therapeutic test called finger thoracostomy. You do a finger thoracostomy. So you just do a bilateral finger thoracostomy. Just at the fifth intercostal space, just lateral to mid-axillary, you just insert your, you go, like the way you insert ICD, you just give a horizontal incision, you pierce with your finger, go to the intercostal space. If there is hemorrhage, you remove it. If there is air, you take it off. And if there is any positive finding, you just insert an ICD and come. So this bilateral finger thoracostomy is a very important diagnostic and a therapeutic test. So I'm finishing this talk now. And the rest we'll continue in the next week. Thank you, sir.
So, what are the questions? Please feel free to ask. Shyam is a brilliant boy. He will answer. Yes.
I just stopped screening it.
Put the whole gallery on. Let us see all those who are attending.
Sir, can you boss, repeat about the difference which he showed in the pneumomediastinum and the pneumothorax and the pneumopericardium part?
Yeah, I will show
The
that.
image.
No, you can just tell them that in a lateral position, even without the image, everybody can understand. If the person is in the lateral, put the patient in a lateral position.
So this actually to differentiate in a lateral decubitus position, what happens is in a pneumopericardium, the air goes up literally. So when you are in a lateral decubitus, where your, for example, when your right side is up, the right part, there is a preferential air goes up inside in a lateral decubitus, but there is no change in pneumomediastinum because it's in the soft tissues. There is no change in the air movement. So that is in the pneumomediastinum. I can share you the picture in the group. I'll do that in the WhatsApp group. I'll share you the picture.
Okay, thank you.
Okay. Hope you're there in the GDS tutorials classes group, right?
Yes.
Yeah, I'll share it in that group.
Dr. Shyam, one question from my side.
Yes,
Are we still doing the finger thoracostomy? I don't think we are practicing this.
Ma'am, it's very rare, ma'am. It is actually a debatable thing. I was discussing this with sir also. But if there's no time, ma'am, if there is no time for any investigation, the patient is literally going in shock. You don't have the time to transport the patient. Then you can definitely try a finger thoracostomy, ma'am.
Yeah. One thing I want to tell the postgraduate students is any patient is unstable, and if you feel that there is a reduced air entry, you have to put in the chest tube, as an adjunct to the primary survey. The chest X-ray and pelvic X-ray are done. So because the patients are coming immediately, if they come immediately after the trauma, many of the chest X-ray findings may not be there. It is always a clinical assessment, even before the pneumothorax develops. Don't hesitate to put in a chest tube because the tension pneumothorax can kill the patient. Hemothorax, you can still wait, but tension pneumothorax can kill the patient. Any stable patient, of course, you will ship the patient to CT wherever the facilities are present. Unstable patient, chest tube if it is indicated. And if you suspect abdominal injury, patient will be shifted to the OT directly. Sir, comments from your side, Dr. Girija Sharma, sir.
Yeah, I would say I was taught exactly the similar way. The answer is the side which has less air entry. Here comes the role of the cheapest instrument called stethoscope, which is unfortunately vanishing from surgical residents. So on auscultation, the side which has less air entry or no air entry, or the side which is having multiple fractures of the rib, which can be picked up by palpation. And if you are in doubt, you put the tube on both sides. If both sides air entry is less.
And
entry of the
yes, sir. Sorry, sir.
No. Entry with that finger guided thoracostomy never leads to injury, even if that side did not have pneumothorax or hemothorax.
So what we do when you're inserting an ICD, you always actually sweep our finger. Sometimes there are lung adhesions present. We need to identify, we sweep the finger and then we insert an ICD. So that good practice. And even they tell that when you're piercing through the parietal pleura, it is always better to insert with your finger than an artery forceps so that you don't injure the lung.
Yes.
So, a finger thoracostomy is a part of even an ICD insertion actually.
Yeah.
One more point I want to add, Dr. Shyam.
Yes, ma'am.
Actually, you made a very good point that peripheral pulses are to be examined for all the patients, especially in thoracic trauma, upper thoracic trauma, clavicular fractures, where the subclavian and axillary artery injuries are common. Before
Very
shifting
good.
the patient, if the pulses are absent, don't hesitate to, enter CT angio as well. Because you can't keep on shifting the patient, get the PMCT done, bring the patient back to ER and again send it for CT angio. So it is a double dose of contrast for the patients. So any supracondylar fractures and any thoracic trauma, clavicular fractures, by default you have to suspect the brachial plexus injuries, and by default you have to suspect the major vessels injuries and get the CT angio done.
Yes, ma'am. Always first rib fracture and clavicle fracture, you always suspect the injury of
Absolutely
these
right.
vessels and also the brachial plexus injury, especially first rib and the clavicle fracture. Yes, ma'am.
One small question for you, Shyam.
Yes, ma'am. Yes, sir.
What is CT gated? What is ECG gated CT?
Yeah, ECG gated CT is during
Well,
diastole.
this
Yes,
is
sir.
not for general surgery residents. This is only for Shyam.
Yes, sir. This
Yes.
ECG guided CT is only done during a diastole, sir. I mean, this is only especially to visualize the heart, sir. Especially, the CT is taken exactly at the diastolic period, sir. So that is known as ECG gated CT scan, sir.
Right. Why diastolic?
I mean, I read it, sir, and I just forgot actually.
It has the practically minimal movement of the heart during diastole. When it is filling, then rather contracting. A very simple logistic.
Yes, sir.
Right?
Yes, sir.
Sir, with your permission, can I add one or two points more?
Yes, sure.
Dr. Shyam has done a wonderful job. Just wanted to add in the pneumomediastinum. You see, the patient is stable. Whenever there is a pneumomediastinum on the CT, you have to, the patient has to undergo bronchoscopy as well as upper GI endoscopy to rule out the esophageal injuries and the tracheobronchial injuries. That is one point. One more point I wanted to tell, I think I've forgotten. Yeah,
Thank you, ma'am.
cardiac injuries, blunt cardiac injuries. Apart from the serial ECGs, we get the troponin T, serial troponin T as well.
Yes, ma'am.
When would you suspect a bronchial injury?
Sir, a massive pneumothorax when it is not getting solved just by ICD insertion, sir.
I would
still a lung fault.
You know the matter, but how you should tell is a collapsed lung, continuous blowing chest tube indicates a bronchial injury. Three things: collapsed lung, continuous blowing chest tube. Right?
Yes, sir.
Something like a bubbling, sir. It comes as an ICD.
Continuous bubbling.
Yeah.
What is the commonest problem associated with the chest tube?
Malposition.
And then second, retained hemothorax.
Retained hemothorax. Clots.
These are two things.
And that is also one of the bread and butter, sir. We do actually retained hemothorax. Evacuation of clots is one of the actually in every list. I mean, every list it's like one case we have retained clots, sir.
Yeah, that's an easy game.
Easy game, yes, sir. Very true.
And
sir, I want to ask one question. In retained pneumothorax, do you put the ICTD on the wall-mounted suction?
Ma'am, we need to know what is the cause of the pneumothorax, ma'am. That is more important. And we usually have a device connected. Actually, in our institute, we have a negative suction device. We also measure the air leak also, how much air leak is coming. We need to know the cause of it. For example, if we have done a decortication procedure, sometimes 200 to 300 ml per minute is a common thing we expect. We ask him to do a very good physiotherapy, it resolves. So all this depends on the pathology. Then we decide these things, ma'am.
Okay, okay.
When would a lung not expand with the patent chest tube?
Sir, if it is a severely consolidated lung, like for a long time it's consolidated, it won't. Severe empyema, like even they have described that empyema more than 1 year, and if it is severely consolidated, you don't expect it to expand. Then we even do a surgery called PC window if it doesn't expand, sir. Pleurocatinous window.
The exact answer would be number 1, large bronchopleural fistula. Number 2, encased lung. Number 3, blocked bronchus. Are you clear?
Yes, sir.
So sometimes the bronchial lumen is blocked by the secretions. So a bronchoscopic suction and venturi inflation helps the expansion of the lung. I think we will devote next session sharp 30 minutes for the chest tube and 30 minutes for thoracotomy.
Thoracotomy, yes, sir.
Right? Any
Yes,
questions from residents? Any suggestions? Please feel free.
They can
Dr.
write
Shyam
on the
has to be a
WhatsApp.
little slow, sir.
Any questions they can write on the WhatsApp, on the
Right.
group. Shyam, you have done excellent.
Thank you, sir.
We are proud of our
Yes,
next
yes.
generation. I'm happy they will carry out the flagship even when we retire. I am preparing another girl for plastic surgery coverage. She is doing plastics in bladder cancer. So I'm motivating all the previous residents that they take over the lead. And so Shyam, when will you have next class?
Once again, I think I confirmed the date. I'll just... Sir, either Monday or Tuesday, I'll just confirm it, sir. Next week, Monday or Tuesday, I'll just confirm my, according to my duty roster, I'll just send it in the group, sir.
Yeah, that's all right.
Either Monday or Tuesday, sir. Either of these 2 days. I think, yes, sir.
So whatever date, doesn't matter. We know, everybody knows the topic. So people
Yes,
will
sir.
be prepared. In between, whenever I get time, I will take a session on fire in operation theatre. This is an important topic, and this can be a question in theory this year because it is covered in detail in Indian Journal of Surgery. See, the new questions only come from Indian Journal Surgery or MEMC update, whatever are the new topics they're asked. So
Yes, sir.
people can prepare fire in OR, which involves all subspecialties.
Yes, sir.
Okay,
Thank you, sir.
good
Thank you
night.
so much.
Everybody, good night. Thank you
Good
for
night.
coming. Okay.
Thank you, sir. Good night.